My name is Brian Morris. I'm a student at Rocky Mountain University of Health Professions, and today I will be presenting a case on a patient with primary complaint of cervicothoracic pain. Patient is a 47-year-old female, examination date June 10th, 2013. Chief complaint of neck and upper trap pain. Photo score of 46, which is 1 point above the average, and she has a low fear avoidance. Primary complaint of neck pain. Symptoms were intermittent and variable. Patient described a dull ache progressing to a sharp pain with increased activity. Pain at best is 0 of 10 and at worst got up to about an 8 of 10. Aggravating factors include 20 minutes of gardening, 20 minutes of chores around the house. And these activities were described as kind of stooping activities with that kind of hunch posture and reaching an 8 of 10 pain. Pain diminished after about 45 minutes of rest, and easing activities or easing factors were pain medication, heat, and laying down. Patient also circled yes to the numbness and tingling on the intake form, but this was described as more of a residual effect from a recent nerve ablation procedure, and she noted things were getting a lot better. P1 does not equal P2. So these are the areas and structures I considered as a source of symptoms. I'll let you guys look over those. So my early hypothesis list pre-interview starts with cervical myelopathy and cervical radiculopathy because of that numbness and tingling that she had circled on the body diagram. Mechanical neck pain secondary to anterior fusion in 2006. Discogenic pain referral, first rib dysfunction, and cervical facet dysfunction above and below the fusion. P1 aggravating factors include gardening for more than 20 minutes, vacuuming and other household chores for more than 20 minutes. P1 easing factors, pain medication, hot bath or shower, and a heat pack. P2 numbness and tingling, as described earlier, is more of a residual thing from the nerve ablation procedure. She noted things are getting a lot better. And she also described getting a similar procedure done in November and having these same symptoms, and this lasting for a couple weeks before going away. So she didn't seem too concerned with the numbness and tingling in the neck. Sleep in 24-hour pattern. She's been having trouble sleeping and typically needs medication throughout the night. Duration of current symptoms is about 2 months. Her mechanism of injury, no known mechanism, but patient really attributes her symptoms to the radiofrequency ablation on March 13th. She described feeling good after the procedure for approximately 1 month before current symptoms started. They were gradually worsening, but have recently plateaued over the last 3 weeks. Significant prior history, radiofrequency ablation in November 2012, March 2013, spinal anterior fusion of C5-C6 in January 2006 due to a ruptured disc. Prior to the surgery, patient was exhibiting cervical radiculopathy down the right arm into the thumb and index finger. After the fusion surgery, symptoms lasted for about 3 weeks before completely subsiding, and patient has not had any radicular symptoms down the arm since. Patient was also in an MVA in 2008 and was going 45 miles an hour when a car pulled out in front of her. She had some soreness and some pain in her neck for about 3 weeks after that, and then those symptoms subsided, and she hasn't had any aggravation since. Previous treatment was facet injections after every 5 months for about 3 years, from 2009 to 2012. She had a total of 6 injections, and she was getting about 6 months relief with each injection. In 2012, the benefits from the injection were only lasting for about 2 months, and her physician kind of offered a new treatment with the radiofrequency ablations, and that's when she started kind of turning to those. Red flag screening, none. There was nothing significant for red flags. Yellow flags, patient did circle yes to the depression screening questions, to 2 of them, but did not want help. As far as imaging, she had an MRI in 2006, X-rays after the MVA in 2008, and that showed degenerative disc disease. A discogram in 2012, which revealed a disc bulge at the C4 spinous level. Medications are listed below. Subjective asterisk signs, self-reported pain rating after gardening for more than 20 minutes, 8 of 10 pain. Self-reported pain rating after performing household chores for more than 20 minutes, 8 of 10 pain. My hypothesis at this point following the subjective exam is mechanical neck pain secondary to anterior fusion with postural dysfunction, discogenic pain referral, first rib dysfunction, cervical facet dysfunction above and below the fusion. The cervical radiculopathy was ruled out with subjective questioning, and visceral pain referral was also ruled out with subjective questioning. Additionally, I did not include P2 beyond subjective because patient described the numbness and tingling symptoms as a similar progression after her last nerve ablation, as mentioned earlier. She was not concerned, and however, I did want to monitor these symptoms moving forward with the exam and kind of as I progressed with my treatments. The CEN's principle, severity of the condition was moderate severity because the pain reached about an 8 of 10 at worst, but only got to that occasionally with increased activity. Patient has noted being very good with activity modification, but she did report her functionality was limited and at a 5 of 10. The irritability is moderate. Patient does get down to a 0 of 10 with intermittent pain, but it only takes about 20 minutes of upper extremity activity to aggravate those symptoms. Symptoms then take approximately 1 hour to go from an 8 of 10 pain down to more of a 2 of 10 manageable level for her. Primary nature is musculoskeletal. Stage of the disorder is chronic. Currently she had been experiencing a gradual worsening of symptoms, but then plateaued about 3 weeks before the evaluation and have not gotten any worse. But she has had pain since 2006 after that fusion, kind of intermittently, and so that kind of put this at more of a chronic stage. Stability, it was stable and reproducible. Symptoms are intermittent and variable on a day-to-day basis. Asterisk signs are also reproducible. So planning the physical exam, I wanted to include active and passive cervical range of motion, segmental mobility above and below the fusion, OA and AA assessment, compression and distraction of the cervical spine, trigger point palpation of the upper traps and levator scapula, and also cervical rotation lateral flexion, CRLF testing for first rib mobility. As far as deferring anything, I did not want to push into the C5, C6 fusion with segmental mobility and CPAs and UPAs. Again, with precautions, I did not want to push into the C5, C6 with mobility testing. Postural observation, she had a forward head and rounded shoulders that I deemed as moderate. She kind of had that hunched posture. Functional movement analysis for asterisk signs, she was really limited in rotation and side bending bilaterally. Quick screening tests for clearing additional joints, the glenohumeral, acromioclavicular, sternoclavicular, and the first rib mobility was all cleared. Neurological exam was also within normal limits. Range of motion for the shoulder was also within normal limits bilaterally. Cervical range of motion was limited in all directions, flexion, extension, side bending, and rotation. Side bending to the left was the most limited, but side bending and rotation both recreated her familiar pain bilaterally. Palpation of C7 spinous process was tender with superficial palpation, and the upper trap and levator scapula revealed trigger point pain that recreated her familiar pain bilaterally with more of deep tissue palpation. Suboccipitals were painful and kind of tender with palpation. As far as the segmental mobility and joint restrictions, thoracic spine was hypomobile from T1 to T7. Patient described some slight pain with CPAs at all segmental levels. Cervical spine mobility was hypermobile from C1 to C4. C7 was painful with CPAs and felt kind of hypomobile. Manual muscle testing was within functional limits. Muscle length, upper trap and levator scapula were moderately restricted. Motor control was within normal limits. Special testing, I included the tick for radiculopathy to be thorough with my physical exam. All of these were negative. Alar and transverse ligament testing was negative. OA and AA assessment was OA was hypomobile with some suboccipital tightness. First rib assessment was equal bilaterally. So looking at the primary hypothesis following the physical examination, mechanical neck pain secondary to an anterior fusion in 2006 was my primary hypothesis with some subsequent postural dysfunction. I also put her in a specific exercise and conditioning treatment-based classification. That was the primary classification, but she also fit a mobility classification because of the range of motion deficits, and so I kind of combined the two. As far as historical asterisk signs, those are listed below again, and physical exam asterisk signs were cervical rotation bilaterally, cervical side bending bilaterally, trigger point palpation, upper trap and levator scap bilaterally. So moving on to more of my plan of care, I expect a full recovery of function for this patient, 90% to 100%. I want to see her 2 times per week for 6 weeks. As far as patient-specific goals for physical therapy, I want her to be able to return to normal activity and recreational and daily activities without pain, so gardening, household chores, vacuuming. She also described liking to go out on the boat on Lake Travis. I also want her to regain pain-free range of motion. If patient has not made any progress after the first 2 weeks of treatment, I'll have to reassess and possibly refer back. And then the overall management strategy will consist of manual therapy, specific strengthening and conditioning exercises, postural, neuromuscular re-education with some DNF retraining, and patient education. Any questions? Go ahead and post on the boards, and thanks for listening, guys.